Good afternoon, family. How's everyone doing? I want to let you know that we have already broken a record. There are more than 900 people on this platform right now. You're going to our exhibit halls, you're listening to videos, and you're actually chatting in the networking lounge. Come out of the networking lounge and come back to the sessions. But 900 people, so let's just keep it all going. So congratulations to us. We're making history here. Now we're going to talk about rare disease in the African American community. Why do we say rare? Because there's a prevalence of African Americans that tend to get this specific disease, and we're talking about hATTR amyloidosis. It is rare, but there are enough people who have it that it is significant to address. One of the interesting things about hATTR amyloidosis is because it mimics other types of diseases that are more common in African Americans, like neuropathy or some form of heart disease. It's often diagnosed. So if you're in a situation where you're seeing your physician, they're giving you a lot of different meds for cardiovascular disease, and you're not seeing any progress, you could have a rare disease such as hATTR amyloidosis. Let me just say a few things about it. It is a rare, inherited, progressively debilitating, and often fatal disease that disproportionately impacts African Americans. 4% of African Americans actually carry a specific TTR gene mutation, which puts them at increased risk for developing hATTR amyloidosis. Last year, Black Health Matters partnered with Alnylam and did more than 6 educational programs in New Orleans, in Chicago, and Philadelphia to talk with the community about hATTR amyloidosis. So we want to shout out to the organizations that supported us, such as Holy Cross Baptist Church in Philadelphia. We worked in several churches in New Orleans, including working with Alpha Kappa Alpha, National Association of Professional Black Women, Franklin Baptist Church. We worked with many organizations, so just too many for us to shout out. Advocate Health in Chicago. Again, we just want to show you some love. We thank you for hosting us as we did these patient education programs. So today, we are fortunate to have an expert speak to us about hATTR amyloidosis, and his name is Dr. Sunil Saith. He is a fellow in cardiac amyloidosis at Columbia University College of Physician and Surgeon. He is also a clinical assistant professor at NYU Langone. After Dr. Saith presents, please go to our exhibit hall and get more information on this disease, because again, your family or relative may have it, and you can present some options to them because you've listened to today's session. We have, again, many exhibitors that will speak to this disease in our exhibit hall, so please stop by. That includes Axia and Alnylam. So now I am happy to introduce you to Dr. Saith, who's going to talk to you about hATTR amyloidosis. Thank you, Dr. Saith.
Thank you very much, Rosalind, for that wonderful introduction. I want to thank certainly everyone for putting together a fantastic event so far. I've been tuning into some of the webinars. There's been some fantastic presentations, and so I have the formidable challenge of presenting hereditary transthyretin cardiac amyloidosis in about 20 minutes, and I certainly want to leave time for some questions and answers. So certainly, I know it's a lot to wrap everyone's head around, and I want to wish everyone, hope everyone's staying safe as well from Brooklyn, New York here. Hope everyone's staying cool as well. It's a little bit of a humid day, so I certainly hope everyone's staying safe. And so thank you for that wonderful introduction. And so let me begin by discussing. So first of all, no financial disclosures of interest. I am the recipient of the Amyloid Foundation travel grant to the International Society of Amyloidosis in Barcelona, which would have been held earlier this year in March, but was postponed. Is now a virtual event because, well, I think we all know why that's happened, but certainly I'm thrilled to be a part of this event, and I'm thrilled that we are going to be able to discuss this. So let me start out first of all by describing a little bit about myself. So who, or perhaps what am I? So I think that this is certainly a very little bit of an interesting background. So I was born in New York City. born over at St. Luke's Hospital, and I was actually in the Bronx, but I also spent some time, part of my childhood, between New York City and Trinidad in the West Indies. And then from there, I moved around quite a bit. So I lived over in Teaneck, just across the river in New Jersey. And then I lived a little bit in Indiana, moved to Michigan, where I went to, I spent half of my childhood there, went to high school there. And then I completed a bachelor's of science from the University of Michigan. And then, as if that wasn't cold enough in Michigan, I went to Minnesota, where I went to the University of Minnesota Medical School. And then I moved to Maryland and DC. I did my internship over in Washington, DC. I also was part of 2 novel programs as well. I did my Master's of Public Health from the University of Southern California. I was a global clinical scholar from Harvard Medical School. And then I moved to New York, where I finished my training. I did a residency in internal medicine, and I did a fellowship in advanced heart failure at NYU, where I got introduced to amyloidosis. And interesting enough, one of the patients I encountered was a patient from Barbados, who unfortunately was diagnosed pretty late stage in this disease. And certainly that piqued my interest further into study. So I was fortunate enough to become the first cardiac amyloidosis fellow at Columbia University, where I'm working with Dr. Matt Moore. And I've been a part of many different research projects and clinical evaluation of patients ongoing, which I will be discussing. I also have an appointment at the clinic as a clinical assistant professor at the NYU School of Medicine. It's a little bit about my background. So you can see here me playing hockey. This is actually in Washington, D.C., but of course this is Michigan. This is my family over in England. So I have a very varied background, which I think is very much germane to this condition. This is my aunt, she's Welsh. This is my uncle, he's Burmese. This is my cousin, who actually lives in Queens. So this is one of my friends, actually. So my background is again, when you look at me, one may not think, nobody ever guesses that I'm from Trinidad. I have Trinidad ethnicity, but I think the very background that I grew up with is certainly something that I think is very fascinating about this condition too as well. So what is transthyretin amyloidosis? This is basically, the best way of explaining this is that it's a deposition of protein fragments that could affect various organs throughout the body. And this forms amyloid. And so it can deposit in various organs. The kidney is one of them, the heart's one of them. I'm going to be focusing on the heart. There are 2 types. Transthyretin is a protein that is synthesized on chromosome 18. And it could come in two forms. It could be a hereditary mutation, and it could also be due to age. So what does amyloid do to the heart? On the left here, you can see that this is the structure of the heart. And on the right, this is a heart that's been affected with amyloid. And so one of the things is that the protein does, it's been known to do several things. One, it enlarges the upper chambers of the heart. This is called the atria. These are the upper chambers of the heart. Blood flows into the ventricles. And what amyloid does is that it thickens the septum, it thickens the wall. And the best analogy that one of my colleagues in the clinical cardiovascular clinical research for the elderly mentioned is the best way of describing this is like a baseball glove, right? It opens and closes. You put some leather in it, it's able to open and close very easily. But imagine if you use plaster instead. Plaster, it's a lot harder to open and close a leather glove. So that's probably the best analogy of what amyloid does, and that makes it very difficult. On the right here are some stains that would be seen in a pathology lab. So these are histological stains that would be used to identify amyloid. I'm going to talk a little bit about how we diagnose it and how we treat it a little bit later. But a little bit of background on how does amyloidosis develop? So proteins are synthesized in the liver, DNA is transcribed into RNA, and RNA becomes proteins. And proteins, what happens over time is that the proteins can either, they're supposed to fold in a correct way. Sometimes what happens is that these proteins may misfold, and when they misfold, they kind of clump together and form these aggregates. And these aggregates become fibrils, which can deposit into various organs. And so among them, what this results in is a restrictive cardiomyopathy. It also results in a neuropathy as well. So people may complain of numbness, tingling, loss of sensation. They may often present with carpal tunnel syndrome bilaterally, so that's another clue that we may see in this condition. But it's a very varied presentation, which also, not only is it rare, as Rosalind alluded to as well, but it can also be a very tricky diagnosis to make. And this is something that we have seen clinically too as well. There are multiple different treatment options that are either currently available or being investigated specifically as it pertains to cardiac amyloidosis. And so there are several targets that we've identified based on our understanding of how amyloidosis develops. This can include impacting amyloidosis at the site of production. So as I mentioned earlier, RNA becomes protein. There are RNA silencers. Patisiran and inotersen are two medications which block the synthesis of RNA into protein. There are also medications which act on the already made protein, and they help to stabilize and prevent it from breaking down. There are a number of medications, among them tafamidis is a medication that some of you may have heard of that was actually FDA approved in the middle of last year in 2019. So this is it's a very exciting time in amyloidosis because there are options aside from before it was pretty much limited in terms of treatment options, which I'll talk about a little bit later. And then there are also mechanisms which can remove the fibrils that deposit into various organs too as well. And so there's some investigational compounds and combinations that are being used. The clinical efficacy is something that's a topic of ongoing interest. This is something that we are studying right now, both at Columbia and at various institutions around the country too as well. Why is this important to Black health? Well, transthyretin amyloidosis is actually a lot more prevalent than we're coming to understand. These are some other prevalence conditions that we understand. Sickle cell anemia, maybe 1 in 500. Hypertrophic cardiomyopathy, which is a type of heart disease that is not due to coronary disease, maybe 1 in 500. Cystic fibrosis and Tay-Sachs disease are other inheritable conditions too as well. But when you think about this, transthyretin amyloidosis can be as prevalent in every 100 people, there may be 3 or 4 people who may be affected with this condition. So I think our understanding of this disease is certainly emerging, and there's a lot of epidemiological evidence that we are examining. So one of the things that we have is a registry of amyloidosis in the United States. And in a sample of 390 patients, about less than half of them will have normal structure of transthyretin. But we see that the mutation that I particularly want to talk about here in the African-American population, I should say people of African descent, because Afro-Caribbean population certainly too as well could be affected with this, as we're finding as well. So the V122I mutation, what this means is that there's a substitution of an amino acid at a certain location. And what this does is it changes the structure and makes it less stable. And as a result, it has a greater propensity to dissociate and become amyloid. And so we've identified that nearly 23% of people in the United States, when it comes to amyloidosis, may have this mutation. There are other mutations that result in different destabilization effects of amyloid. And then there's a lot of miscellaneous mutations as well. There's a 50-50 chance of inheriting this from mom or dad. It is autosomal dominant. It has a median age of about 76 years, and it tends to have a overwhelming male predominance as we've identified, but particularly when it comes to mutations, again, this is a 50-50 inheritance. So it's very important to understand that it's not just something that you would think of just males, but also females too as well. And the most important thing, one of the most important things I should highlight is that the survivability of this is quite low, actually, is that this is less than 60% at 3 years. And so to give a frame of reference, the 5-year survival for prostate cancer is about 60%. And for heart failure in general is about 60% too as well. So as somebody who has focused in heart failure, this is certainly something that is quite alarming. It's certainly something that we should bring to the attention, because there are options that we can look at. There are things that we can do about it. This is the frequency, allele frequency that we understand of this. We've understand this sub-Saharan Africa. It can vary from as low as 0.5% in Malawi to in West Africa. It could be as high as 3.6 to 3.8%. So this is very important when we think about the genetics of this disease And when we think about throughout the Caribbean, throughout the United States, throughout many parts of the world, where the prevalence of this condition, the gene itself has been observed to be found. So people who have this allele frequency in this genetic condition is certainly something that to be aware of. And if we were to frame this in terms of the United States population, say that there's 318 million people in the United States and 38.9 million who self-identify as Black, 1.3 million may have the V122I mutation. And that may mean that there are maybe as many as 150,000 people who may have V122I and amyloidosis. And when we consider that there are 650,000 people with heart failure as it is in the United States, which is continuing to grow, this is something that we are going to increasingly see, I think, more and more, the more that we realize and the more that we look for it. This is, again, an example of somebody, let's say, father, your dad has this condition. He may pass this as a 50-50 chance it could pass to his son or his daughter. So it's certainly something that's very important to recognize. So the ability to pass this gene down is certainly a 100%. But one of the challenging aspects of this condition too as well is that this is something where, again, the clinical penetrance is not known yet. So this is something that we are also investigating to understand a little bit better about who tends to end up having heart failure, who ends up manifesting with this condition, and why do they manifest with it. This is something that we're still looking at right now. In the Afro-Caribbean population, over 1,100 people who have been admitted to the hospital with heart failure and that require medications to get rid of the extra fluid. 170 of them, or 14.9%, were Afro-Caribbean, and 17 of them, or 10% of this sample, were found to have the V122I mutation. And the median survival in amyloid is again quite concerning. It's a little bit less than 3 years, 34 months compared to 59 months in people who have amyloid cardiomyopathy versus non-amyloid cardiomyopathy. And this is something that's very important because one of the trickiest things that I've seen in managing people with heart failure, particularly as it pertains to African-American population, is that oftentimes their etiology, where it can be due to ischemic heart disease, it can be due to coronary disease. One of the most challenging aspects is when it's not due to coronary disease. There's a lot of arrhythmias. There are a lot of challenges as it pertains in terms of medications. We have a lot of evidence to support the management, but the underlying etiologies for heart failure is something that is an area of interest. Tafamidis is a medication that reduces all-cause mortality and hospitalizations. This came from the hATTR ACT trial, which was published 2 years ago by my mentor, Dr. Moore. 33% reduction in overall mortality, meaning that if you treat 7 to 8 patients, you'll prevent 1 death over 2.5 years. Pretty substantial reduction. Also significant reduction in hospitalization too as well. For every 4 patients that are treated, you're preventing 1 hospitalization per year. So this is certainly a very, very potent medication that has hit the market in the last year. The earlier, the better. NYHA stands for New York Heart Association. This is how we grade people in terms of like symptoms of heart failure. So New York Heart Association class 1 heart failure is, for example, somebody, maybe they're able to walk the length of Central Park from 59th Street to 125th Street. They might be able to walk that, do okay, but they have heart failure. New York Heart Association class 2, these are people that they're able to walk the length. Maybe they'll get up halfway through and maybe they'll feel short of breath. They may have to stop. They may feel a little bit tired. But New York Heart Association class 3, this is somebody who, again, if you start at 59th Street, they may get short of breath by the time they get to 61st or 62nd Street. They'll notice that they're short of breath. They'll have noticeable symptoms. But the relative risk reduction in death is significant in people the earlier that we identify compared to people who are symptomatic. There is a benefit, but the benefit's observed much greater in people that the earlier that we're able to treat this. So how are we attempting to meet this unmet need? So earlier diagnosis. So how do we diagnose this? As I pointed out, there are histological slides, which means that we take a sample of your heart, we snip it, and then we put it under a slide. That doesn't sound very pleasant. And I don't think you need to be a doctor to understand certainly that it doesn't sound pleasant, and certainly it doesn't necessarily always mean that you may sample it. So fortunately, in the last in the last 5 years or so, we've been able to understand that we can actually make this diagnosis using a nuclear scan, which is something that we do over at Columbia. And so this is called a pyrophosphate scan, or a PYP scan. And so this is actually kind of a fun fact, was in the 1970s, was that we actually used this before coronary angiography to be able to diagnose people if they had a myocardial infarction. So if someone had a heart attack, we were able to identify these people. We came to understand later, once we had other tools, that this pyrophosphate scan, pyrophosphate has an affinity for transthyretin. So people who have transthyretin or TTR deposited into the heart, pyrophosphate, if you inject it, can bind to these and light up the heart. And so we can actually identify people with the help of some additional blood tests to distinguish TTR amyloid from other forms of amyloidosis, and to figure out whether or not somebody has TTR amyloidosis. So this is something we've learned in the last 5 years, which is pretty exciting, is that rather than having to go into the lab and take a snip of your heart, we're able to do this non-invasively. So the paradigm of TTR amyloidosis has changed dramatically in the last few years. This used to be thought of as a rare disease, and actually on Tuesday I gave a lecture to the residents over at NYU on heart failure. And one of the things that we say is that when you hear hoofbeats, think horses, not zebras. But this is something that we're understanding, that whereas many doctors would think to themselves this is a rare disease, we're coming to realize it's increasingly more common. And the diagnosis is not limited to having a heart biopsy. We can do this non-invasively. There are many different treatment options right now, not just tafamidis, which is FDA approved, but patisiran, which is already approved for peripheral neuropathy. And the Apollo B trial is something that's ongoing right now, that we are working on, where we're examining this particularly in heart failure patients. So this, and there are a number of other medications too as well that we are looking at and examining, particularly with heart failure. So the last thing I'm going to talk about is the screening for cardiac amyloidosis using nuclear imaging in the minority population. It's, or we abbreviate it as the SCAN-MP trial. So this is our aim for this study, is to change the approach of TTR amyloidosis by screening and early diagnosis. So the earlier we can diagnose, the better. This is a study that we are working on with Boston Medical Center too as well. It's a prospective cohort study where we are enrolling Caribbean Black and Caribbean Hispanic patients who have been identified to have heart failure. They undergo the PYP scan. We obtain the clinical biomarkers and obtain an electrocardiogram as well as an echocardiogram, as well as genetic testing to help to better understand the prevalence, the phenotype, and as well as the outcomes of patients who have been diagnosed with TTR amyloidosis in the minority population. That may be due to genetic causes or could be due to wild type transthyretin amyloidosis too as well. So this is something that's an ongoing study that we are enrolling patients in right now too as well. This was in the world past in the Clinical Cardiovascular Research Lab for the Elderly, our get together in December 2019, before we ever heard of social distancing, before we ever heard of COVID-19. I do recognize certainly that this is something that has certainly impacted a lot of different things, but in the world, to say the least, this is me back here. This is my mentor, Dr. Moore. I have to thank him for his support, and he's been a wonderful mentor. I've been very, very fortunate to work with him over this past year. And this is our lab manager, Stephen Helmke, incredibly smart guy. Who he gave me the baseball glove analogy, by the way, so you could thank him too as well. An incredibly smart guy. And they've been a wonderful team to work with. Everybody here in the lab, I have to thank them. So Jeffany, Hannah, one of the cardiovascular fellows, Margie, one of the nurse practitioners, Samantha, who is also a research assistant in the lab too as well. And we have Henry, who is Matt's right-hand man. So we have a wonderful group. And I want to thank you all for taking the time to tune in. And I will open it up to questions, and hopefully there's enough time for that. So I see the chat box here, number of questions. So question number one, do you recommend that we screen children for this disease? We would not screen children. The answer would be no. The screening for children, the screening for this disease, one of the things that right now we are still understanding the clinical penetrance of this disease. And people that may have the mutation may not always manifest with the disease. So this is something that is not something that, this is something that in discussing with the genetics counselor, this is not something that I think we need to screen for in the pediatric population. Question number 2, how aware is my primary doctor about this disease? I think that this, the bottom line is certainly there are a lot of diseases that are out there, and we are becoming aware of lots of different diseases in terms of primary care. So the spectrum can vary. This is something that I think that the bottom line is in the workup for heart failure. If someone has symptoms where they feel short of breath, they would be referred to a cardiologist, and a cardiologist would do a workup, and there is a pretty comprehensive workup that cardiologists will do to evaluate. Most common things, of course, ischemic heart disease, but certainly they will also investigate to make sure that this is not due to other forms of heart disease. It's very tricky. There's a lot in the evaluation process that goes into figuring out why does somebody have heart failure and to identify this sooner. And I think that this is something that the cardiology community and that doctors are becoming increasingly aware about. So I think that this is something that we are seeing more awareness. So question number 3, my father died from cardiac amyloidosis. Is it hereditary? I think it's difficult to say offhand because there are many types. It could be due to hereditary mutations. It could also be due to age. So this is one of the more challenging questions that we are seeing with heart disease. And so this is something that requires a little bit more investigations. I'm unfortunately not able to answer it offhand, just based on if someone had died from cardiac amyloidosis. Does that mean that I may be at risk? That's a great question. Again, everyone who has the mutation can be passed down, but not everyone will manifest with heart disease. And people may have other conditions. I should also point that out too as well. So I think certainly, while it certainly could be a concern, it certainly doesn't negate the fact that there are other conditions too as well. So it requires a careful evaluation, and I think that that's something that where a part of a complete workup is very important. Question number 4, can you find out if you have this disease from 23andMe? You know, it's funny because actually I think my sister had done a 23andMe. You cannot identify it from 23andMe actually. It's not something, it requires a little more of a formal genetics evaluation. So it's, whereas you may be able to identify, roughly speaking, I think that the sequencing of the proteins is something that is beyond the scope from commercial genetics. So it's not something that you would be able to see from a 23andMe or for any commercial genetics testing as well. Is there a regional skew to this disease? We're finding actually, this is something that's a great question. We're finding out more and more. The epidemiology is ongoing. May you please send me more information on amyloidosis? I'm more than happy to. I think certainly what we can work on is giving the right referrals. We're happy to take patients. My colleagues they've reached out to me too as well in terms of better understanding this and referring their patients for further workup. So that's something that we can do. If someone has tested positive for the mutation but isn't showing symptoms, what should they be doing? Watching and waiting for symptoms is terrifying. I absolutely agree. It certainly is something that understanding if you may have a genetic propensity for something is certainly something that it's not easy to understand. We talk about this in many different kinds of genetic diseases. But I think the important thing to realize certainly is I think the bottom line is routine follow-up with primary care is certainly an important thing. Can anything regular in the blood tests indicate a possibility for this condition? I lost my son due to cardiomyopathy. He was 46. I have a few male cousins that have issues too. I'm awfully sorry to hear about your son. I think certainly with young people, I think certainly the bottom line is speaking with your primary care doctor is certainly the important thing. And primary care doctors, one of the things that we work on with primary care is to help make appropriate referrals, and certainly we can facilitate that too as well. And can anything, we talked about the blood tests, so And I think, how are we creating awareness in the general public? Advocacy groups are usually the route. Yes, you're absolutely correct. There's the Amyloidosis Foundation. There are multiple support groups that are available too as well. I think certainly we can, with heart failure in general too as well. So there are options too as well. Does this disease affect the aortic valve? Great question. Yes, there are some studies that we are finding where it may be related to aortic stenosis. Again, that would be a disease of the elderly, but parsing that from age-related changes is tricky. Tingling and numbness, telltale sign of this disease. I think certainly it could be. It's not 100% certain. That requires, I think, again, comes back to seeing the primary care doctor. So I think that I see that there are a number of questions. But I think that when it comes to what the bottom line for many of these are all fantastic questions. And I think certainly the important thing here is being able to have a dialogue with your primary care physicians. I think certainly with primary care doctors, people that may have heart failure, again, if they're feeling short of breath, if they're feeling fatigued, if they are feeling like they have, again, if something doesn't feel right, I think it's important to discuss with your primary care doctor. And your primary care doctor will facilitate appropriate recommendations. And in light of a context of a family history, certainly if there is a premature history of people who have been affected by heart disease, that's something that certainly would warrant a referral to a cardiologist and further evaluation to examine furthermore. Because as I mentioned, we've talked a lot, of course, the focus here is transthyretin amyloidosis. There are other conditions that can also cause heart disease too as well. And I realize certainly that as we understand that the prevalence of this condition is maybe more frequent than we realize. But there's a lot of ongoing research to help examine this and to better understand the risk benefit of further workup, further treatment. And this is something that I think that we're looking at. I see that another member of the audience, I've recently been prescribed verapamil. Is it possible I should ask for further tests? I think it's a good discussion to have with your doctors. I think that the bottom line is that to understand that when it comes to medications, people are prescribed medications, and a good thing to do is that if you're feeling, if something doesn't feel right with any recent changes, whether it be from tests, whether it be from new medications, whether it be, I don't want to say just specifically verapamil, but other medications in general, it's always a great idea to discuss with your doctors. I realize that certainly within COVID-19 that this is a increasing challenge, and this is something that we're faced with all around in medicine. But one of the things with telehealth visits and also facilitating an open conversation, it's very important. If something doesn't feel right for you, discuss and talk with your doctor. And I think having that open dialogue is one of the biggest things that's important. But I think that when it comes to advocacy groups, there are groups, and I think one of the things certainly at Columbia that we are doing is that with the studies, we have a very diverse group over at Columbia where in our lab too as well. And so I'm certainly happy to facilitate and provide the contact information for anybody who's interested in discussing with your primary care doctors. That's something that we are certainly open to make sure that there's a greater awareness. Feeling of coldness to the extremities along with numbness. Again, neuropathy can be due to many other things. Diabetes is a very common condition that we see. So that's where again, it becomes in terms of a appropriate workup. And so again, when you hear hoofbeats, think horses, not zebras, but I think certainly one of the things that we look at as part of a thorough workup, and this is something that I emphasize in my instruction when I'm teaching house staff and teaching residents in the hospital, is to do a complete workup here. So I think right now, I want to thank you all for all the questions. I just want to sort of wrap up right now. And I want to say thank you everyone for tuning in. It's been a fantastic event thus far. And I'm happy to help in any way. Okay?